Welcome to the Lymphoma Research Foundation's update on adolescent and young adult lymphoma webinar. I'm Polly, and I'll be the moderator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete the evaluation of this program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I'm pleased to introduce Jessie Brown. Jessie Brown is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jessie.
Thank you. And thank you to each of you for taking the time to join us on today's update on adolescent and young adult lymphoma webinar. We'd like to thank our sponsor of this webinar, Bristol Myers Squibb. In addition, the program is supported through the Lymphoma Research Foundation's AYA Lymphoma Consortium and its founding sponsor, the Paul Foundation. We have callers from 29 states across the U.S., as well as patients and caregivers from 6 countries around the world. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. We have a wonderful program planned for you today, and I'm honored to introduce you to Dr. Tara Henderson. Dr. Henderson is a pediatric hematologist and oncologist and professor of pediatrics at the University of Chicago. She also serves as the director of the Childhood, Adolescent, and Young Adult Survivorship Center and a co-leader of the Cancer Prevention and Control Program. Thank you so much, Dr. Henderson, for speaking at our webinar today. I'll now turn the talk over to you.
Thank you so much. It's my real pleasure to be here and get to interact with people all over the country, and I'll just get going. So I'm going to talk a little bit today about a topic near and dear to my heart, adolescent and young adult lymphoma. So just to give a little bit of overview of the topic, I think it's always important to think about the definition of adolescent and young adult as we begin. The NIH, or the National Institute of Health, defines adolescent and young adult cancer as cancer diagnosed between the ages of 15 and 39 years. And we see about 70,000 patients diagnosed with new cancer in this age group annually in the U.S., and that's about 6 times that of children ages 0 to 14 years of age. So this slide actually represents the different tumors that make up the different tumors that make up those diagnosed with cancer in this age group. And I just would like to point out the dark blue bar here for the 15 to 19-year-olds, for the 20 to 24-year-olds, really is the preponderance of cancers, and these are all lymphomas. We see a little less of this in our older young adults. These patients we start to see more thyroid disease, more breast cancers, but as you can see, focusing in on lymphoma is really important in this age group. Something else important to know about adolescents and young adults with cancer is our advances in terms of cure have been a little bit slower than with younger children, those 14 and under, and adults over the age of 40. So these bars represent the percent increase in cure over the past 5 years. And you can see in the younger children down here where we see these large increases in improvement, and the increase in the patients 15 to 39 are really clearly not as good, with in fact the 30 to 34-year-olds looking almost as if they've had decreased improvement in survival. We see these trends overall as well in lymphoma patients. So the top bar here, and I apologize if you can't see what that said, this right here is Hodgkin lymphoma. So again, the Hodgkin lymphoma cure rates, we've been doing better, just not as well as the young kids or the older adults. And then with non-Hodgkin lymphoma, I think the 15 to 25-year-olds are doing a little bit better, but these older young adults are in fact not seeing any improvement in their survival. As a result of these disparities, the National Cancer Institute and Livestrong in 2006 assembled a progress review group, which was a group of experts around adolescent and young adult cancer, to develop a call to action. And in this call to action, they said, we need to figure out what explains these outcome differences so we can address them. We know that there's multiple areas to consider. There's the personal or patient. So these are patients that are in transition periods in their life. They're moving from living at home with their parents to going to college, to moving away from college, getting their first job. They have issues with how they interact with their family and community. In terms of societal issues, these are patients that may have difficulty with getting health insurance. And then health professional refers to the fact that these are patients sort of in a crossover period. So particularly like for patients 18 to 22, they could either go to a pediatric oncologist, or if you live more in the community and not near an academic medical center, you might go see a medical oncologist. And interestingly, the approaches to lymphoma based on whether you were treated with a pediatric or adult provider could be different. This gets a little bit more into the details of each of those topics that I mentioned, but basically in terms of the personal and patient and why we're seeing these issues, these patients have the mobility and transition, as I mentioned. They're not aware of their symptoms as much. So you can imagine they're in college, they're studying hard, they don't think of themselves as having to worry about getting cancer. And so we know that there's a lack of awareness that leads to delay in diagnosis. Depending on the social situation or the patient, there could be issues with compliance and adherence. And as I mentioned, also issues with health insurance, finances, and also we're seeing that there's differences in biology. Likewise, in the family and community, also a lack of awareness and inadequate resources, and the societal, as I mentioned already. And as we talk about the health professional in more detail, I think, again, we're dealing with a lack of awareness on the part of some of our primary care providers that don't really think of a cancer diagnosis at the top of their mind in terms of differential, which can lead to a delay in diagnosis. Again, the approach can be different for these patients in terms of whether you're seen by a pediatric or adult primary care provider and then referred out to a pediatric or adult oncology provider. We don't see the same clinical trial participation in this population. So in the pediatric population, we're actually accruing to clinical trial almost 70% of our patients. And these numbers significantly fall off when you're cared for in the community. And so this is an issue that we're actively trying to think about. Likewise, as I mentioned, we may be seeing biology differences in this population, and getting specimens for biology studies also may differ. We see some tolerance to therapy differently in these patients. So, for example, a pediatric patient may be able to tolerate much higher doses of chemotherapy than a young adult. We may see differences in side effect profiles based on the age that you are. And again, the other thing is the ability to relate to patients who are in care. So a lot of times a patient will go to a medical oncologist and they're in the waiting room with a lot of older patients, and so that's very isolating. So I want to touch base a little bit on clinical trial participation by age at diagnosis. So I had mentioned earlier that those patients under 15 years of age, most of these patients are treated at a cancer center that has NCI-sponsored trials, and as a result, 2/3 of these patients are enrolled on trial. And as a result of our ability to do these clinical trials, at this point, about 85% of patients are long-term survivors. This significantly drops off in the 15 to 19-year-old age group, where 20 to 35% are treated at a cancer center that would potentially have NCI trials, and then only 10% are enrolled on the trials. And then when we go up to the 29 and 30-year-old age group, we're down to 1 to 2% of these patients who are enrolled on clinical trials. So that gets to the question of, does location of care matter? So I mentioned to you that these patients have crossover in terms of whether they're cared for by a pediatric or an adult provider. And we've actually done studies at the University of Chicago, both in Hodgkin lymphoma and also in some leukemia patients where we looked at the differences in outcome on whether you were treated at a pediatric center versus an adult center. And so for Hodgkin lymphoma who are being treated on North American clinical trials, we found that patients who are 17 to 21 years of age have better outcomes if they were treated on pediatric trials. My colleagues at University of Alabama, Birmingham also did a study looking at cancer centers in California and found that patients treated at NCI-designated cancer centers also have better outcomes compared to those treated at community-based practices. So that gets to, why is that? Why do patients need, in this age group, to be treated in a particular place? And we think that's because there's a multifaceted need for these patients. And we worked with the American Society of Clinical Oncology to develop a resource guide to really lay out what it is that adolescents and young adults need for their care beyond our standard oncology patients. First, as you can imagine, fertility preservation is very important. These are the patients that are in prime reproductive years. We may be giving them agents such as alkylators or radiation that could involve the pelvis that could impact that fertility risk. So it's always important to have a discussion of risk and refer to a reproductive endocrinologist. We're learning more and more that younger patients have higher prevalence of germline cancer predisposition syndromes than we previously realized when they're diagnosed with cancer. So we have found that patients of this age group, particularly patients with hematologic malignancies as well as sarcomas, be referred to genetic testing. And once they have counseling, potentially genetic tests as well. These patients need clinical trials. So even if these patients are treated at community sites, if there's a way for the providers to know of available clinical trials, just have a resource so that the patients can have the opportunity to think about appropriate clinical trials for their disease. These patients, as you can imagine, as I've discussed already, have significant psychosocial issues. These patients need to have access to financial counselors, social workers, and often they need intensive counseling or group support. And then the other thing that we need to talk about is survivorship, and that's what I want to shift over to in the next part of my call. So despite the fact that our outcomes haven't been as good in this population, we still are curing the vast majority of patients with lymphoma. And so they're going to go on after they're done with their chemotherapy or radiation to live long lives, and we need to make sure that their healthcare moving forward addresses all of their needs after cancer. I did want to note that because of all the focus on adolescent and young adult lymphoma with the support of the Lymphoma Research Foundation, we are now actually opening trials focused on this age group. So this Southwest Oncology Group, also known as SWOG, recently opened S1826. And this is a clinical trial for newly diagnosed high-risk Hodgkin lymphoma patients ages 12 years and up. And so basically the SWOG group has collaborated with the Children's Oncology Group, which is the consortium of clinical trials for pediatrics, as well as the other adult oncology consortia in the U.S. to develop this trial with the hope of all of these patients receiving the same treatment. We want to make sure that we're not giving patients siloed treatment based on whether they were in a pediatric or adult center. We want to make sure that the standard of the care is at the highest level, and it's at the highest level across the board. So these patients are currently entering the trial randomized to compare the efficacy or the effectiveness of brentuximab vedotin, which is a targeted drug antibody conjugate. So the drug is attached to a protein that targets a specific protein on Hodgkin lymphoma cells, which is called CD30. And this is being compared to a PD-1 inhibitor called nivolumab in combination with standard chemotherapy. We are also currently actively working on developing also another pediatric and adult intergroup study for newly diagnosed early-stage Hodgkin lymphoma patients. And this study is, we also want to look at the impact of immunotherapy in combination with standard chemotherapy to maintain very high cure rates, but also think about decreasing late effects or the long-term effects in our survivors. So as we shift away from our treatment of these patients, I want to talk a little bit about survivorship. And I also want to start from saying our understanding of adolescent and young adult cancer survivorship is informed in large part by childhood and adolescent and young adult survivors diagnosed with their cancer before the age of 21 years. And this is because we have a large cohort in North America, and we have cohorts in the Netherlands as well as Great Britain, where the data on long-term survivors came from patients that were treated with their cancer ages 21 and younger. But it's important to note that many of these cohorts have large numbers of lymphoma patients. So we've been able to learn a lot about the exposure in these patients and how these patients do long-term. So I think when we think about survivorship, as I already alluded to, it is really a great success story in cancer and in medicine. So we've gone from the 1960s to a cure rate of about 10% to now we are curing almost 85% of anyone diagnosed with childhood, adolescent, or young adult cancer. And this is due to laboratory discovery, more intense therapy, entry onto clinical trials, supportive care, as well as new therapies, including stem cell transplant, targeted agents, and immunotherapy. But there's a cost to this cure. We are seeing chronic health issues in cancer survivors. And so when we looked at survivors treated between 1970 and 1986 in the North American cohort, the Childhood Cancer Survivor Study, which is a cohort of over 14,000 childhood cancer survivors who have been followed since 1994, we found that by 30 years after their cancer, 75% of these patients have at least one chronic health condition. And 2/5 of these survivors have a severe or life-threatening condition. And this is 8 times more likely to have a severe or life-threatening condition than their siblings. And what are late effects? These are the health conditions that you can often get years or decades after your initial treatment that are an impact of that therapy. And they really can impact anything that the drugs or cancer or radiotherapy touch in your body. So we can see impact in growth and development, fertility and reproduction. We can see impact on any organ system. We see significant impact on the development of second cancers and recurrence. And we also see a whole laundry list of psychosocial issues that range from mental health disorders, issues with body image, fatigue, issues with sleep and concentration. Patients have issues with completing their education, having vocational limitations, issues with access to healthcare and insurance, debt from the financial impact of the treatment, as well as impact on their peer and family interactions. So what contributes to getting these late effects or chronic health conditions after cancer? So first, you could have some predisposition condition or genetics that lead to this before your cancer diagnosis. And then what age you were at diagnosis, whether you were male or female, and your race can impact your risk of late effects. Having a genetic predisposition, so a gene that may predispose you to cancer or another cancer, puts you at higher risk. Your tumor factors and how you were treated for that tumor impacts your risk of late effects. If you had any significant treatment events during that time, your health behaviors, so your use of tobacco, your diet, whether you drink, your exercise practice, or sun exposure. And we've learned recently that the aging process really impacts your risk of late effects. And in fact, your aging process itself can be impacted through cancer treatment. So really, cancer survivorship is a new chronic disease paradigm that we're seeing, and it's distinct from the classic chronic disease paradigm because basically once the patient is cured, we often don't see signs or sequelae for often years or decades. So the traditional chronic disease model that we often see in pediatrics or adolescents, such as juvenile type 1 diabetes or sickle cell disease or cystic fibrosis, is inadequate to describe the evolution of health issues in survivors, because for those patients, as they transition from the pediatric stage to adult stage, they still have those conditions, and it's not like there's a period where there are no issues that you are dealing with almost a ticking time bomb. So the question is, how do we ensure that the health care of adolescent and young adult cancer survivors is maximized so that their health risks are minimized and the quality of life is optimal? So the Institute of Medicine helped us with that, and they had two calls to action. In 2003, there was a call to action, and this says here childhood cancer survivorship, but actually this is a call for all childhood, adolescent, and young adult survivors. And the call was, in 2003, they recommended that these survivors receive risk-based health care throughout the lifespan. What is risk-based health care? It includes monitoring for cancer reoccurrence, surveillance and intervention for late effects and second cancers, as well as prevention and education around the patient's lifestyles, health behaviors, educating them about their previous therapies, and assisting them with financial challenges. In response to these recommendations, in 2003, the Children's Oncology Group has developed long-term follow-up guidelines for survivors of childhood, adolescent, and young adult cancer. And in these guidelines, there are 166 sections which detail exposure-based potential late effects and screening recommendations. The committee in the Children's Oncology Group has graded the evidence linking this exposure to potential late effect. They've developed second cancer screening recommendations for both standard and high-risk groups. So I'll talk about this in a moment, but basically a high-risk group would be a woman exposed to chest radiation for, say, a lymphoma as an adolescent or young adult. And then in these guidelines, there's also health links that are for patients and their families. So providers can provide these health links to help with the education process. I want to give an illustrated example of an adolescent and young adult cancer-related late effects that requires lifelong risk-based health care to minimize morbidity and mortality. So JN is a 33-year-old woman who was diagnosed with stage 2A nodular Hodgkin lymphoma in March 1990 at the age of 16. She was treated with 3,900 gray of mantle radiation at the University of Chicago. So just to point out, mantle radiation is a field that we no longer use for Hodgkin lymphoma, but the field basically goes up under the ears, over the armpits, and down over the chest to underneath the diaphragm. So really encompasses the whole neck and chest. She received no chemotherapy. But in October 2008, she developed some shoulder pain. So she went to her primary care doctor who did an x-ray of the shoulder, and at the time she saw a mass in her breast. She was referred to the University of Chicago, where we did a mammogram and a biopsy, which revealed stage 1 breast cancer. She was treated with bilateral mastectomy and tamoxifen for 5 years, and I'm happy to report she's still a long-term survivor. So I just want to talk a little bit about breast cancer risk. And this is something that we've looked at in a lot of detail. This is the most highly prevalent second malignancy in childhood, adolescent, and young adult cancer survivors, particularly in women. And you can see here, this blue line represents Hodgkin lymphoma survivors. And my colleagues at Sloan Kettering and I looked at the risk of Hodgkin lymphoma and compared the risk of breast cancer in Hodgkin lymphoma survivors and compared the risk of breast cancer in BRCA1 and 2 gene mutation carriers. So BRCA1 and 2 is the breast cancer gene, as well as the SEER benchmark. So the SEER benchmark tells us the risk of breast cancer in the general population. So basically what we're seeing is the risk of breast cancer after Hodgkin lymphoma is higher than if you had a BRCA1 or 2 mutation, and significantly higher than that of the general population. We see that risk is associated with increasing dose of radiation to the chest, and we also see that the field is very important. So this yellow line is whether you had a mantle field exposure, and this blue line represents a mediastinal exposure, so the beam of radiation getting much more focused on the center of your chest where the Hodgkin is. And so you can see that the risk gets much lower when you focus down that field. We looked back it's now a decade ago, to decide, will early screening help these women? And so we did an in-depth systematic review of the literature, and we found that the median age of developing breast cancer in these women is young. The interval from radiation to breast cancer is often short, like 10 to 20 years, and we did find that the 5-year survival was strongly associated with the stage at diagnosis. So basically that tells us that women who are diagnosed with early stage disease, so stage 1 or 2, are going to most likely be cured. So as a result, we decided in the Children's Oncology Group's second malignancy screening guideline group, which I co-chair with my colleague Paul Nathan, we recommended annual mammography and breast MRI starting at the age of 25 or 8 years after the exposure to chest radiotherapy. This is in contrast to the recommendations in the general population, where patients are told to begin discussion of breast cancer screening around the age of 40 with your primary care doctor, and it's strongly recommended to begin at age 50 with mammogram only. So the question is, are survivors receiving this risk-based health care, such as early breast cancer screening for exposure to chest radiation for an adolescent and young adult lymphoma? Well, first, I think it's really important to understand where adult survivors of childhood and adolescent and young adult cancer get their care. And what's really fascinating is actually they don't come to the cancer center. So less than 15% are getting their long-term care at the cancer center, whereas over 85% are getting their care from their primary care doctor in the community. We asked, are these survivors receiving the exposure-based surveillance based on the guidelines? We went back into the childhood cancer survivor study, and we looked at both women at average risk for second cancers and those at high risk for second cancers. So those at average risk, we looked at women in the general population, so with a recommendation to get a mammogram every 1 to 2 years over the age of 40, and then cervical cancer screening to get a pap smear every 3 years starting at the age of 21. And then we looked at survivors at high risk for second cancer. And so these recommendations were our previous set of recommendations where we had a radiation threshold. We don't have one anymore, but just to set the stage, for women who got over 20 gray of radiation therapy to the chest, annual mammography starting at 8 years after radiation or age 25. For those who got 30 gray of radiation to the abdomen or pelvis, colonoscopy every 5 years starting at the age of 35 for colorectal cancer screening. And for anyone who got any radiotherapy, skin cancer screening by a dermatologist in the radiated areas yearly. So what was really interesting is when we looked at those average risk patients, 2/3 of the women were getting their mammograms over the age of 40, and 81% were getting their pap smears. But these patients at high risk were not doing so well. So only 12% were getting recommended colorectal cancer screening, less than half were getting mammograms, and about a quarter were getting their recommended skin exams. And so our observation was that survivors were adherent to population-based screening, but not to treatment exposure-based high-risk surveillance. And we think this is a lack of knowledge and not a lack of motivation. And that's because when we looked in another study that we did subsequent to this one, we found that the only predictor of breast cancer screening in women exposed to chest radiotherapy is whether their physician recommended that they do so. So that got us to the question of, our physicians, those primary care doctors that I mentioned to you, are they aware of the Institute of Medicine recommendations and the available long-term follow-up guidelines for childhood cancer survivors? So we did nationally representative survey studies of every pediatric oncologist in the United States of about 2,500 family physicians in North America and Canada, and of a representative sample of general internists in the United States, and we looked at about 2,500 of those as well. And in this survey, we had an over 60% response rate, which is excellent for a physician-based survey, and we included a vignette and asked about long-term follow-up of these patients in the vignette, so we sort of quizzed the doctors. So we asked about CL, a 29-year-old woman treated for Hodgkin lymphoma when she was 16 years of age. She received combination chemo, including adriamycin, cyclophosphamide, and mantle radiation. And we asked questions about cardiac screening, thyroid function screening, and breast cancer screening. And these are the results of the physician's knowledge of the guidelines. So I want to point out the blue line is their concordance with breast cancer screening, the red is cardiac, the green is thyroid, and purple is all. And importantly, we actually allowed for just mammogram as a correct answer, as well as mammogram as an MRI, because we were just switching over to the recommendations for breast mammogram and MRI at this time. So when you see these results, just keep that in mind, that we were actually being generous with your answer. So our pediatric oncologists did okay, and I'm going to give ourselves a little bit of a pat on the back because we developed some of these guidelines, but I still think that we could have done better. Only a third were actually got all three of the questions correct. But when we get to the family physicians and the general internists, who are the providers actually caring for our adult survivors of childhood and AYA cancer, we weren't doing as well. Now, the thyroid function test, everyone was doing pretty well with across the board. But what I want to focus you in on is breast and cardiac cancer screening. So you can see that less than 20% of family physicians were concordant with our breast cancer screening recommendation, and 10% were concordant with yearly echocardiograms for exposure to anthracycline and chest radiation. Likewise, our general internists, only about 25% were concordant with the breast cancer screening recommendations, and just over 10% were concordant with the echocardiographic recommendations. And meanwhile, less than 5% of either family physicians and general internists got all of these questions correct. So I'm talking a little bit about what our barriers are, but how do we overcome them? How do we have solutions to ensure that our survivors are getting the risk-based healthcare that we need? So first, as part of our survey study, we asked the primary care doctors, what do they think they need to appropriately take care of these patients, and do they want to take care of them? And so the family physicians and the general internists both said, we want to take care of these patients. We just need a few things to do so. We need a treatment summary or letter from the treating oncologist, access to the surveillance guideline, and a way to get back to the cancer center and contact the treating physician. And this sort of says that I think that us as oncologists need to do a better job with ensuring integration of oncology and primary care throughout the cancer care continuum. So it's not that when you're diagnosed with your cancer, you fall off from talking to your primary care doctor anymore, and then you go into the void of the oncology practice, and then when you're done, you go back to the primary care doctor. There needs to be communication and integrated communication throughout the time the patient is diagnosed, treated, early follow-up, and long-term follow-up. So I want to get back to how our understanding of the long-term outcomes of cancer survivors impact cancer treatments. First, I want to give some kudos to how we're doing, and importantly, we are doing better in terms of long-term outcomes with our modern therapies. So this is data from the Childhood Cancer Survivor Study, and in the first slide I showed patients diagnosed between 1970 and 1986. And in the past 5 years, we've actually expanded that cohort to almost double in size. We now follow almost 25,000 childhood cancer survivors, and those patients were treated between 1970 and 1999. And because of this expansion, we've been able to look at the impact of when you were treated on your outcome. And so you can see that the 15-year mortality rate went from 10.7% for patients treated in the 1970s to 7.9% of those treated in the 1980s, to now those treated in the 1990s, less than 6% of them have long-term mortality at 15 years. And we think that this is due to risk stratification of therapy. So basically, this is a lymphoma talk, so basically we can identify those low-risk patients and try to reduce their therapy. We do this all the time for Hodgkin lymphoma, that we try to titrate up or down who needs more chemotherapy, who needs radiation, and who we can ultimately try to give new targeted agents. We also are doing better with screening and early detection of late effects, treatment of these late effects, as well as supportive care. So in summary, I hope I've shown to you today that adolescents and young adults with cancer are a population with unique needs that really need to be addressed in order to ensure their best outcomes. We need to be thinking about this from the moment of diagnosis through long-term survivorship. And we need to be continually thinking about new clinical trials focused on this age group. We also need to think about that ASCO resource list that I talked to you about. Every patient in this age group, we need to be thinking not just about what chemotherapy and radiation and immunotherapy we give them, but need to be thinking about the whole person and their family, and think about what financial resources they need, what psychosocial resources they need, what fertility resources they need, and how to ensure that people are getting the genetic counseling they need. So in order to do this, we also have to think about how we do take care of patients across the cancer care continuum, and this really involves research. We really need to continue to understand what the long-term outcomes of this population are. We now are bringing new therapies to these patients. We're bringing in PD-1 inhibitors, also known as nivolumab or pembrolizumab. We are brentuximab vedotin, which is a drug I mentioned earlier, and we need to be thinking about how we study the long-term effects associated with them. We need to continue to identify factors associated with the disparate outcomes in this population. So we need to continue to do focused biology studies, think about treatments specifically for this patient population, where this patient is being treated, and the supports they need. I really want to thank everybody for their attention. I am open for questions. I apologize if I spoke too quickly. I'm used to looking at my audience in the eye, and I do miss seeing your eyes, but I'll look forward to answering any questions you have.
Great. Thank you so much, Dr. Henderson. Before we open the program up to questions, I just want to share some information with you on the Lymphoma Research Foundation that may be helpful to you as you navigate lymphoma and long-term survivorship. LRF is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or via LRF's website at lymphoma.org if you're on the phone. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options in clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. The LSN connects patients and caregivers with volunteers who have similar experiences to help give others strength to meet the challenges they may have to face. We also offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. We have comprehensive books on understanding NHL, HL, CLL, and the transplantation process. We offer a variety of easy-to-understand fact sheets on each of the subtypes of lymphoma, as well as supportive care topics, and an adolescent and young adult lymphoma fact sheet that may be relevant to your experience. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. This app is available for free download in the Apple App Store and in Google Play. I'd encourage you all to download it today. Finally, we have launched our COVID-19 Learning Center to support lymphoma patients and caregivers through this challenging time. Please visit our Learning Center for access to webinars, articles, and other resources specific to COVID-19. I really hope you'll take advantage of some of the great resources and services that LRF provides. If you have questions regarding what you learned today, or if you need information about relevant treatment options and supportive care resources, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. Thank you all again for your time today. We'll now begin our Q&A portion of the program. Just as a reminder, please keep your questions as general as possible so that the entire audience can benefit from their answers. If you'd like to ask a question, please submit your question through the Q&A box on the screen. We'll take as many questions as possible, but if you have a question that does not get answered, you can always reach out to the LRF helpline at 800-500-9976. And now we have our first question from online. What genetic tests, if any, are relevant for lymphoma?
So we are learning more and more about the genetics of lymphoma as we speak. There are ongoing research studies that are going on to try to better understand the impact of germline predisposition on the development of hematologic malignancies or blood cancers. We are seeing that there are risks for Hodgkin lymphoma in families. We don't have an identified gene around that. When we looked at the germline cancer predisposition risk of survivors in the childhood cancer survivor study and at St. Jude, it does look like there's an increased risk of having a BRCA2 mutation in some of our non-Hodgkin lymphoma survivors. Now, when I say risk, that doesn't mean that they all have this gene. There's just a slightly increased risk there. So the important thing to do is when you're diagnosed with a cancer at a young age is to be referred to a genetic counselor, because the way we can start learning more about this is to take a detailed family history pedigree, and then the genetic counselor can, based on your family history pedigree, recommend what genetic testing can be done. So, and we're just learning more and more that this is really important. I mean, it's very interesting. When I did my training in the 2000s, we're like, oh, well, less than 5% of these patients would have a germline cancer predisposition syndrome. And since that time, the numbers are looking higher. And again, with lymphoma, Hodgkin lymphoma, we don't have a specified gene, but I think that we need to talk to genetic counselors and learn more and more. I have a patient that I'm taking care of right now who his mom had Hodgkin lymphoma. I have many patients that we have families. And my colleague at the University of Chicago, her name is Lucy Godley, she has an open study where she's trying to get tissue from families with Hodgkin lymphoma and other types of lymphoma to understand what genes are associated with their development.
Great, thank you so much. Our next question is from online. At age 15, I was diagnosed with thyroid cancer. I underwent I-131 radiation. As you have suggested, it took years for the second cancer to hit. I had follicular in 32 areas in my body and a reoccurrence of thyroid cancer. I was treated at City of Hope, and they mentioned this reoccurrence was from the radiation. Do you agree that the radiation likely brought on a lymphoma?
So in terms of I-131, that's something that we don't, we're not prescribing as much as pediatric patients, but it does have a radiation effect and can be associated with the development of other cancers. So I think there is a risk of its association. But in terms of the absolute risk of that, I actually would have to look that up and don't know the specific answer.
Okay, great, thank you. Next question, what type of questions should AYA patients be asking their doctors when a treatment decision has been made?
In terms of when they're first diagnosed, is that the question?
Yes. Yeah.
So that's a really excellent question, and I think that the resource guide, and I'm happy to send that out to everyone, but I think that the important thing to think about is Are there available clinical trials for my treatment? Have you, if it's not an adolescent and young adult specific clinic, have they conferred with other experts across the country? I will tell you that for all these patients with adolescent and young adult cancer, we all talk to each other. I never feel like we all need to learn from each other, because 70,000 new diagnoses a year for every type of cancer between that age group actually, in the scheme of things, isn't a lot, because what we're talking about is, less than 1,000 new lymphoma cases. And so it really takes the experts talking to one another and talking through if anyone knows of any trials or what was a thing that they haven't thought of or what have you. And I think the other thing that you need to ask when you have this diagnosis is that list of questions about being referred for genetic counseling, being referred for fertility preservation. Whether you're a man or a woman, we have fertility preservations for options for both. I think offering every patient in this age group psychosocial support, talking to a social worker about finances, making sure that you're referred to a financial counselor, making sure that your insurance is okay, making sure that you or your the caregiver that's with you, needs psychosocial support. It's all critical for doing well.
Okay. Next question is, you mentioned screening and early detection. How do we go about that, especially those with a family history?
Who gets what screening and early detection really depends on what exposure that you had. And then that exposure really, the Children's Oncology Group guidelines that I mentioned, so there's a guidelines, you can go look at them yourself, actually, at survivorshipguidelines.org. So that will say, okay, if you've had exposure to chest radiation before the age of 30, you should start breast cancer screening with MRI and mammogram starting 8 years after your treatment, or at the age 25, whichever occurs last. And I think that patients understanding that risk and your oncologist understanding those screening guidelines and, discussing them with your primary care doctor is critical. I think asking your oncologist when you complete your therapy to give you a summary of your treatment and recommendations for follow-up is almost like having a roadmap for the rest of your life. And that's something that, whether you move or you have to switch doctors, you have that roadmap and you can say to that primary care doctor, hey, I had chest radiation before the age of 30 and I need to get this screening done. Likewise, if you get genetic testing and say you were to find out that you carry the breast cancer gene, there are specific breast cancer screening guidelines if you have germline cancer predisposition syndrome that are different than the general population. Similar to our women exposed to chest radiation, those women also need early breast cancer screening. And so the genetic counselor who would do the counseling and testing can work with you and your primary care or oncologist to develop screening guidelines based on whatever gene you may or may not have.
Great, thank you. Next question is, are there any current studies focused on the social, psychological effects on young adult survivors?
Yes, for sure. So this has become a pretty robust field, and there are studies going both at different institutions as well as through our cohorts to examine different interventions to support patients in terms of their psychosocial outcomes. We actually just did a big study where we were examining the financial toxicity or the impact of having had cancer as a child on your long-term financial outcomes as a survivor, and we're just getting that data out now. There's been studies looking at health behaviors, so smoking, alcohol use, vaping, and trying to develop intervention studies targeting that. There are psychologists throughout the country that are doing psychological interventions for these patients, and that's, I think it's all really key. We've been really lucky at the University of Chicago. We have a multidisciplinary clinic where we have both adult oncologists as well as pediatric oncologists, a pediatric and adult social worker, and we have a psychologist and a neuropsychologist in our clinic to provide patients with that support from the time of diagnosis throughout their long-term survivorship. And I think it's really fortunate, and we see the benefit these patients have. So I think it's always important to think about the psychosocial supports these patients need.
Great. Thank you so much. Our next question is, why is AYA participation in clinical trials so low? What can be done to increase participation?
I think that it's a multifactorial reason. I think some of that is, many of these patients are not being treated at pediatric centers. So like I mentioned, older adults are not going on to clinical trials to the same level that pediatric patients are. So we're sort of a boutique kind of practice in pediatrics. Most of us are in academic medical centers, and so we've been able to enroll, as I mentioned, almost 70% of our patients on clinical trial. Adolescents and young adults are not, a lot of them are being treated in the community where they don't have access to these clinical trials. Some of the trials are designed for older adults, as I mentioned. Patients who are on Medicaid, we've been seeing that there's loopholes in the Medicaid system. So if your insurance is Medicaid-based, the Medicaid won't pay for standard of care testing if you're on a clinical trial. So as a result of that loophole, people aren't going on clinical trials. And so this is something we're working on as advocates to work with our legislature to try to fix that loophole. We are trying to think about these barriers to clinical trials. I know at the Alliance for Clinical Trials, they're doing studies right now to look at risk factors for the sort of what predicts this age group patient going on a trial, so we can understand even further the causes. But it's something that we're focused on. And I think that this, as I mentioned earlier, that the cooperative groups thinking about cross pediatric and adult trials together, our hope is by doing that, it'll really bring this age group to the forefront and more patients will go on trials.
Great, thank you so much. Just in connection with that, we have another question. What role does direct social media outreach have to build awareness about clinical trials?
That's a good question. So in terms of our work in the National Institute of Health cooperative group, to date, we haven't really been able to advertise on social media. In fact, I've had some studies through the Children Oncology Group, and just the way it's set up at this point, we haven't been able to use social media for that purpose because of issues with privacy and health information. So this almost has to be done outside of our doctor-patient relationship kind of thing is my understanding, but it's a very important point. It's just something we haven't been able to do because of some of the regulations that are in place.
Okay, thank you. Next question is, are there any factors that can be seen as early detectors or risk factors for AYA lymphomas? At this point, we don't really have a predictor or a way to screen for early detection of lymphoma. I think that, as I mentioned, my colleague, Lucy Godley, is really working hard at understanding the familial risk of leukemia and lymphoma. And I think if we can really get a better understanding of some of these families, then we could have a way to be on the lookout. But interestingly, I just had a patient diagnosed with Hodgkin's who had a cousin that had Hodgkin's, and this patient has a twin. And the dad said to me, well, how do we screen the twin? And the answer is you can't really screen that. There is no way to screen the twin. So I think that
the patient needs to, if there's any new signs or symptoms, they need to come to the hospital, but it's not like there's any specific test that we could use to screen that patient. We also sent that that is one family in particular that we sent to Dr. Godley to see if we can, in a research way, understand more about their disease from a biologic basis.
Great. Thank you so much, Dr. Henderson. I think we have time for one more question, and then we'll turn it back over to our moderator. Our last question is, following treatment, what types of specialists should AYA patients be seeing?
I think that following treatment, I refer to specialists based on if you have any health needs per se. So, I mean, I think it's important, in the young adult age group to not lose track of your primary care. So you still need to be getting the immunizations you need. You still should be going to your gynecologist to get the pap smears that you need, that kind of thing. I think oncologists can work with your primary care physician if you're not going to a cancer center-based long-term follow-up program to get the screenings and things that you need. But I don't think you need to necessarily see a specialist unless you're having issues. So what kind of issue, what do you mean by that? Well, if, say, you've had chest radiation or bleomycin for your lymphoma and the patient's short of breath, and the doctor has done a pulmonary function test, it may look a little abnormal, I would refer the patient to pulmonary. I also, many patients with lymphoma will get medicines called in the anthracycline family, so that's like doxorubicin, and also will get chest radiation. And in those patients, I follow their echocardiograms every couple of years. And if I were to see any changes to the echocardiogram or the patient had other cardiac risk factors, I would refer them to a cardiologist. But there isn't a kind of blanket subspecialist I would send you to unless it was necessary.
Thank you again to each of you for joining us on today's call, and we hope you found the information both informative and also hopeful. We'd also like to thank our sponsor again for making this program possible, Bristol Myers Squibb, and also thank our supporting partner, the Paul Foundation. Please remember, if you have any additional questions or would like to be connected with someone else who has been impacted by lymphoma, and you can reach out to the LRF helpline at 800-500-9976. Also, at the conclusion of this program, you will receive an email prompting you to complete a program evaluation. I would ask that you please take a few moments to complete this brief evaluation, as these are important for helping LRF to ensure they deliver the most useful and meaningful programming to you. And with that, I would like to thank you all again for joining us, and have a wonderful day.